that are going to talk about some ideas and strategies and some of their priorities. So today we're here to listen. We're not going to make any decisions today. We just want to hear some of your ideas and where you think our best dollars can be spent on some long-term strategic ideas to really push our community forward when it comes to mental health. Whether it's children or adults, we know we have some gaps in our services, and we really want to try to make a difference for long-term strategies and initiatives. So with that, I think I'd like Sarah and then to introduce our panel, and then we'll get started. This is not on Zoom today, but it is on Facebook Live.
Thanks, Angela. So I'm Sarah. I reached out to most of you to be here today, and just want to reiterate that, the goal here is to provide the board with some basic information about kind of a global view on where we're at with mental health in our community today, whether it's adult system or children's. And from there, the intent is to start a work group that will start to narrow down how we can use this one-time investment to make a big impact on those. So as I shared in the email, this isn't the time that we're gonna, and Angela just mentioned, this isn't the time that we're gonna, be talking about individual proposals for organizations and things of that nature, but what's kind of the global view of mental health as it is today in our community. So I think we'll just go down the line and have each of you take about 5 minutes or so to talk about what mental health looks like in our community from your perspective and your organization's perspective. And then we will have a time at the end for public comments as well. And we'll be monitoring Facebook for questions that we can address at the end as well. And for public comments, those will be done up at the podium up front at the end. And yeah, if there's a representative from a group who wants to share something, you'll be welcome to do that at the end. So,
Sarah, could I remind the panelists to speak directly into the microphone? It's hard for the audience to hear if you don't.
We will pass it right down. So, you want to go first?
My name is Vicki Steer, and I work for Child Serve. And what I'd like to do is I would really like to introduce our CEO, Dr. Wallach, and have her talk about Child Serve and some of the issues that we're seeing.
Thank you, Vicki. Thank you, supervisors. Great opportunity. I'm the CEO of Child Serve. We serve children with special health care needs. About 30% of them also have co-occurring mental health, behavioral health conditions. The combination is quite challenging, requires significant investment in specialty providers and programs to serve them. Currently, we have over 500 children on our wait list for mental health therapy and 200 for psychology. So our wait lists have just been climbing and climbing, as many other organizations have as well. The need is pressing. So whatever we can do to come to the table as experts in pediatric care, as experts in children's mental health, behavioral health conditions, we would love to come together and try to find some solutions. We serve primarily children in central Iowa, about 2,500 in Polk County and 5,000 across the state. So we have a very wide reach. And again, we bring a whole team of experts to the table to help with solutions. So.
Can you speak a little bit to 500 kids on the wait list? Do you know why so many? I mean, that's, I think, kind of what we're trying to get at through these conversations is the why. Where's the gap? Is it providers? Is it education?
Yeah, the gap is multifactorial. Certainly the pandemic has had a huge impact on all of us and overall well-being, including mental health well-being, particularly with children. Over 20% of children have some type of mental health, behavioral health condition. So the wait lists were there prior to the pandemic. It's just made things worse. There's a significant issue with providers. Sadly, in Iowa and in other states, the reimbursement for mental health, behavioral health services is so low that providers simply can't make a go of it in the business of providing care for children and adults. So we've actually had a couple pediatric providers who take Medicaid patients, step out of the business because they just simply can't make a go of it. So payment for providers is critical to part of the fix. I know one-time funds don't always do that, but we do need some help in order to get more providers back into the business of mental health.
Quick question on that, because I was curious. We went through the whole process a number of years ago on the privatization of Medicaid. And I know back then we were losing providers across the state based on at least slow payment and not getting paid and what have you. And those smaller nonprofits couldn't make payroll at the end of the day. I think a lot of them, got out of the business. But are you saying that the delay in payments or the actual level of payment is too low?
I think some of the systems issues about getting paid on time, getting proper authorizations have improved. We've been certainly working very hard on that over the last 4 or 5 years. It's actually payment rates is the bigger issue. The more of the rate limiting step is the rates, which haven't really changed in years. And that's what's really cost prohibitive for many providers.
Okay, thank you.
Terry, a question for you. And I think I know the answer to this already, but I'll ask anyway. How's Child Serve doing on staff and retention and hiring and those kinds of things?
Yeah. Overall, we're doing quite well. We've been able to recruit and retain at levels that we were at prior to the pandemic. We have had significant shortages in nurses, but we also face across Iowa a shortage in mental health providers, critical shortage in mental health providers. So that is always a tough recruit, even prior to the pandemic.
Thank you.
Thanks, Terry.
Thank you.
Peggy, you want to be next?
Sure.
Good morning, everybody. Peggy Hubbard. I'm the Executive Director of NAMI Iowa. That's the National Alliance on Mental Illness. Thanks for inviting us here today. Appreciate it. And what an exciting opportunity you have to use a windfall to really make some long-term significant changes for the county. It's wonderful. So NAMI is not provider-focused. We are not a provider of services. NAMI is all about training people with lived experience, and those are people with a mental health diagnosis or loved ones of the family members of those, to share their own story in different ways that help teach about mental health challenges or support others or educate people about it in the community. We're a national organization. We have chapters in all 50 states. We are the state chapter. We have over 600 affiliates nationwide, and we have 14 local affiliates here in Iowa, including a brand new NAMI affiliate in Polk County. And we have 8 signature programs that we offer. They're all research or evidence-based, meaning that they have been researched for effectiveness. We train all our presenters very thoroughly, and we are very serious about fidelity and making sure that the programs are delivered with fidelity. So what I see right now, the gap in Polk County, is peer-based programs, education, support, and others that are given by people with lived experience. And that's what we focus and specialize on. We have great plans to do new outreach in Polk County through Methia Little-Smith, who is our Polk County leader. She has a special focus on outreach to minority people of color, minority communities, LGBTQ, which she feels have been underserved by peer-based services, and I agree with her. So we have family-to-family and peer-to-peer, which are our 8-week classes that are kind of the backbone of NAMI. But we also have family and peer support groups. We have a class called Basics, which is especially for parents of young children who have serious emotional disorders. We have Homefront, which is a variation especially for the families of military or veterans. And then we have 2 programs that those are all done at the local level. we train all the teachers and presenters, anywhere from 5 hours up to 2 days of training. I always joke that NAMI has never seen a binder it doesn't like, so we've got lots of big binders that go with it. There's 2 programs that we do statewide. One is Provider. That is the collaboration we have with Des Moines University, which many of you may have heard of. It's a class, either 4-hour seminar or 15-hour class to teach clinicians about how to be better providers of mental health care, about the collaborative model of care. And all third-year medical students at DMU are now required to take the 15-hour provider class. We're also teaching it to their physical therapy and physician assistant classes. And we just started teaching it at University of Iowa School of Medicine in January. And so now all their medical students are going to receive this training. So we're very excited about that. We're also in discussions with the Department of Corrections to provide this training at all the prisons for all the staff. So that's Provider. And then the other one is Ending the Silence, which is a 50-minute class designed for middle and high school students. It's a great entree to the concept of what is mental illness, and if you or someone you know has it, how do you get help? What do you do? Our manager of that program right now is in Davenport, teaching it to hundreds of middle and high school kids and teachers who are gathered for that sole purpose. So we delivered that program to 1,200 people in the month of January, and we're on track to deliver it to over 2,000 in February. But we still have a lot of ground to cover in Polk County. That program is free. It can be done virtually or in person for anyone who wants it. So my plea is to make an investment in a long-term peer-based training and services, and also consider opening and supporting a wellness center, which is a drop-in center for peers to come to, which we do not currently have in Polk County. But that's something that NAMIs and other places have done. So that's my pitch. Thank you.
Thank you, Peggy. Bill?
Thank you, Angela.
Oh, you got your own, okay.
I do have my own, thank you.
I'll pass.
I'm Bill Brock. I'm a member of First Unitarian Church of Des Moines, and our church is a proud member of Amos. On behalf of Amos, thank you so much for inviting us to participate in this important work. Amos stands for a Mid-Iowa Organizing Strategy. It was founded in 1996 and has grown to over 40 church and nonprofit civic organizations representing approximately 10,000 central Iowa families. We're an advocacy group, all volunteer advocacy group. We're not a service provider. But what brings us here today is our work on children's mental health crisis response, particularly the skilled workforce gap in that area. After the failed 2017 Des Moines vote to impose an additional 1-cent sales tax, city leaders sought Amos's public support for a new go at a sales tax increase. We responded we would support if that money was used for the needs that we were able to identify. The city agreed. Thereafter, Amos canvassed neighborhoods across the city, held meetings in churches, nonprofits, and schools asking folks for their thoughts on the best uses for the sales tax proceeds. Children's mental health crisis was identified as one of those top uses. The sales tax passed in 2018, and that money has been devoted to that purpose. In 2019, the legislature passed a bill requiring counties to put mental health crisis services for children in place by July 1 of last year. And we are so pleased that that has happened, and we really appreciate the funding and the support from the board. And we really look forward to continue to work with you as we work to see best practices implemented. Now, we have seen a bit of a roadblock in filling some of those positions. Talked to Steve Johnson this morning, and they do have some of the positions filled, and that is great news, great news. But still, we don't have overnight service. And part of the problem is the difficulty in hiring people. Now, last fall, Amos leaders convened meetings with representatives of Easter Seals and Broadlawns for an update on the implementation of these services. And right up front, we were told the lack of trained professionals is an impediment. In addition, families who were members of Amos institutions told of long waits for appointments with therapists and limited access to other needed services. Stories from parents and professionals in K through 12 schools also reference difficulties in accessing needed services. To gather additional information, Amos convened a summit in December with more than a dozen mental brain health providers and community shareholders. In sum, we heard that the pandemic has only exacerbated workforce shortages and community need. Our conversations revealed the greatest deficit is in independently licensed mental health professionals, which requires a master's degree plus experience. Specifically, a shortage of licensed independent social workers and licensed mental health counselors, though other mental brain health professional vacancies exist. Unfortunately, community healthcare providers have trouble retaining those professionals, and they face a limited pool of potential applicants to fill openings and new positions. We also learned of the great need for mental health professionals representative of the population of Polk County, particularly bilingual, multilingual therapists and therapist representation in refugee immigrant communities and communities of people of color. We further heard that community providers who don't limit the number of Medicaid cases they take are in particular need of staff retention and recruitment. In sum, retaining and being able to fill positions with independently licensed mental health professionals is key to filling the gaps made worse by COVID. Now, Amos has some thoughts in this area. We believe that it would be beneficial for county ARPA funds to be devoted to strengthening and expanding the mental health therapist workforce in Polk County by fostering retention and recruitment. And we have a notion of doing that through a two-pronged approach. One, assist Polk County professionals with student loan repayment over a 4-year period to foster retention. And two, provide master's degree and licensure support scholarships for individuals in underrepresented groups who, as a condition of receipt, would be required to work for a Polk County provider during acquisition of licensure hours, and upon licensure, agree to a contract of at least 2 years to work for a Polk County provider. Now, we followed up with those who attended our December summit regarding this proposal, as well as other community stakeholders, and you may receive a letter of support from some of them. Amos looks forward to this opportunity to refine an approach for retention and recruitment, working with the subject matter experts on this panel. And we are so pleased to be in this really wonderful group. So thank you very much, and we look forward to working with you as you have an important decision to make about how to distribute these vital funds. Thanks.
Thanks, Bill. And we have received some letters. Steve?
Thanks to the board and Sarah for inviting me here. We support Broadlawn's Medical Center, Steve Johnson, and we definitely support the comments that have made so far, especially NAMI through a wellness center. We do have to, we submitted 8 recommendations that are not specific in any way to what Broadlawn's Medical Center, but really a view on our community. And I agree with I've been in this business a way long time, and we still lack meaningful. I know we tried with the Rainbow Center and what was our next name? Yeah, the meaningful opportunities for people with serious mental illnesses to have purposeful activity during the day. Right, we've done a great job of doing community-based services, right? People, the majority of our people with serious mental illnesses in Polk County are living in the community, and that is great. They have services coming to them from places like Broadlawn, but there's not, even despite our workforce issues, we still do not have full exposure of people having meaningful opportunities during the day, especially when they're symptomatic and they can't fit into a regular work environment. So that is on our list. I've emailed this list to Sarah. So we think we said sort of large day job center. I think it could totally be primarily peer run, and so I think that's a great idea. We support Amos and Bill. We've worked closely with them, and that's number 1 on our list is workforce. So we would totally support that, and they They hosted a great group in December, so there's no need for us to reinvent that. They've done a lot of work there, but it is living stipends and tuition reimbursement. So we've got 2 Broadlawns staff that are in the Drake Counseling Center now. Both are, juggling a job, going to class at night at the Drake Masters in Counseling program. The tuition reimbursement is great, but also then because they've got a job during the day, just like the rest of us. They're going to school at night. So having some type of a living stipend to be able to help them make all that meet, because then you have to do a large practicum internship in your second year, and that's hard to pull off while you're working and going to school. So anyway,
Is that master's a 2-year, right?
yes, but if you go full bore, it can extend out to 4 years depending on how quickly you're taking classes.
Okay.
But it can be done, and working full time and did 2 years. I did it back in the day, so it's not easy. I did my internship at the St. Louis County Jail, so that was an exciting opportunity. It was an exciting opportunity. So anyway, so we totally support those 2 things, and those are on our list. Probably a little bit closer to our radar screen is, we're licensed for 200 beds. If you take our 44 inpatient psych beds, all the rest of the family birthing, medical beds, ICU, we're licensed for 200 beds, and we've been bumping up against that, especially as the pandemic's been in full swing prior to this time. And so this has put a magnifying glass on our most vulnerable populations, primarily adults, because we don't hospitalize children, so I'd defer to Child Serve on the comments so far on children. But the top 3, and again, I want to see this in the context of this is not its own pandemic. This is a smaller number of people. We've been successful in Polk County for putting most of our people in the community, living in the community, and that's great. But the sort of the top 3 here are persons with a serious mental illness that are either stuck in the hospital, stuck in jail, or in prison and coming back to Polk County. So that'd be number 1. Persons with dementia. So we have this, as you know, this will get worse. So we have, again, it's not a great number, but a week doesn't go by that you don't have a family bringing somebody to our emergency room with dementia and issues related to being able to cope with that at home and needing. So we end up putting them in a medical bed and a psychiatric bed, and then just trying to figure out how to do the placement. So that's number 2. Number 3, certainly we all know this, persons with addictive disorder. I know the board's worked for a long time to get a sobering center in place, and I hope that can happen. I'm sorry, Broadlawns cannot be the lead in that, but that's just from our medical position. But I think so persons with a serious mental illness, persons with dementia, persons with addictive disorders, then also persons with physical frailties. So many of us have been down to San Antonio. You've seen this shelter down there that can handle persons on crutches. They've got a whole separate unit there, persons with crutches, persons with wheelchairs, persons on oxygen. I know CIS does handle some of those right now, but we had a person in our crisis observation center last year for about a week because nobody would take somebody that was on oxygen and he was homeless. So we kept him in crisis observation until he could get on a little bit of a different oxygen thing. So I think we do need to copycat that from San Antonio. I mean, I walked in that unit there. I know Annie did too, and I think it's not a medical unit. You don't have nurses in there. You just need a separate place where people can get a little bit extra assistance if they're in a wheelchair. They're carrying around a tank of oxygen, and if San Antonio can do it, we should be able to do it.
And it's a place for people with disabilities of some sort?
It's really highlighted on physical frailties plus being homeless. So, if you're on crutches and you're homeless and you don't have anywhere to go, I know CIS takes care of some of those people right now, but there are still some people left behind, especially people that are, maybe have just post-surgery or on oxygen. They can't go to a shelter. So I think that's a gap. And then so within those populations I just mentioned, second on our list is the MCOs, intensive residential. But I do think we will need some type of initial capital spending for a provider to step into this, because this is sort of like our current residential, but on steroids, because you're handling people that cannot be handled by our current system. So they get stuck in our hospital, they get stuck in Polk County Jail, or they're potentially in prison and coming back here. So those are people that are all under the radar right now. I think we need to monitor them better and have better, again, it's not a huge number. We're talking about probably in the area of not more than 50 adults, but it's still, they need a residential that has really, in my mind, a campus, has secure areas that are quiet, where you can separate people from the population. And it's the reason I say campus is that you've got some buffer zone from law enforcement, so you don't continually get people being arrested and going back to jail. So that's our number 2, is the intensive residential. You've heard me talk about that before, and I think that really the copycat from that is Carbondale, Illinois. So that's where we've got a number of Iowans that are down there right now, primarily under a brain injury, funny, but they have other mental health disorders, and Carbondale does exactly what I'm talking about. If somebody needs a 2 staff to 1 because someone's very symptomatic, then they can do that. And this is well known at the top of DHS. So DHS is working on this. There is ongoing funding, but there could be initial one-time money to help a provider put this in place.
I'm just curious, Steve, is that at the university there at Southern Illinois? Where's that?
Yes. So they use the university. It's Nora Restorative is the organization, and they have a continuum of care from very what I'd call subacute care all the way down to job coaching, similar to like On with Life. And so you're exactly right. They use University of Southern Illinois and Carbondale, the behavior analyst program and the psychology program for staff. So, because you do, and I think that's smart. So intensive residential, second on our list. Third is some type of a residential supervised care for persons with dementia. So we do think that will continue to be a growing need. They don't necessarily need to be in the hospital. So during the pandemic, we've had somebody in a dementia in a very nice medical room that they don't need. And then we've had to sometimes, not be able to serve everybody in a timely manner because we've got this person with dementia sitting in a medical bed. So we think that is Broadlawn, as is a safety net hospital. We don't turn people away. So we're going to, but I'm just trying to give you some feedback as our system has been tested during the pandemic. These are the populations that are coming out as most in need. So we've got eight on here. I've spoken to, sort of our top 4 here, and you'll get our full list as well. But I appreciate the time, and I don't necessarily think that Broadlawn's needs to be. Of course, the living stipends, tuition reimbursement would be available to our staff, and we'd be very appreciative of that. But I think we do hospital really well, and I think we've also got providers in this area that do residential really well, and that could really step up in that space. I think we've got staff providers that do dementia really well, and maybe not from a residential standpoint, more of a nursing facility standpoint, which is all unto itself. But I do think that is going to be a continuing need as we move off. So I thank you for your time.
Thanks, Steve.
Steve, a couple of questions for you.
Yeah, sure.
You and Bill both mentioned tuition reimbursement and mitigation, those kinds of things. Have you, either one of you could answer this question, maybe if you have the numbers, maybe you don't, maybe it's more of an idea stage at this point, because I've got a lot of email on it and found it interesting and compelling, actually. Do we have it kind of gamed out as how many is the right number, or how does that work? How do we assign a cost to that?
A cost to?
I mean, how many, you said tuition reimbursement, how many?
You're talking about the intensive residential?
No.
Tuition
Sorry, tuition reimbursement. How many?
Yeah. I mean, we have a gap to fill because
Amos
we're short.
has a proposal, I think, that they've come
Right.
up with a tuition reimbursement and some scholarships for folks.
You've got a number for that, Bill? Okay.
He does.
Okay.
what was included, I got a copy of it, I think yesterday was the first I'd seen the actual full proposal, but I think it was 20 for the first category of reimbursement and 20 for the master's level. So I think the discussion that we'll have to tease out once we get into the work group is that the right number? Is that gonna, have an impact? Is that gonna bring in new people? Is that going to in fact fill the gap that
Retain.
yeah.
Yes, and that is exactly right. Thanks, Sarah. It is 20 each. And, those numbers came from input from people in the community who provide these services. And we thought it would make a significant improvement.
All right,
And
great. I'll take a look at that. Thanks very much.
And there are other, I know there's, Polk County Health Services has had some workforce webinars and really out in the community doing this kind of work. So I'd like, to get with them to see. And then I think we need to talk to educators to see what their numbers and what it looks like for them to see what they can do for us. So that's a great start, and we certainly will look at that, but I think we still have to do our homework. Well, you all have to do your homework.
You're exactly right.
Bill, the language that you mentioned earlier during your comments about the requirements of the scholarships and specifically the 2 years, 2-year contract of employment, is there some boilerplate language that you use, or where did that specific language come from? I like it. I like the thought of it and what you've said. I clearly haven't read it all, but so where did you get that?
Again, I think that just was our idea. I don't think we looked at a particular boilerplate that's in use anywhere, but we thought it very important that if we're going to make that investment, that it come back and pay off in Polk County.
Exactly. No, I totally agree with you. So, okay.
Yeah, I'm thinking about more than 2 years, however.
That's what I was just thinking. I could probably even go to 3 or 4 maybe,
Yeah.
but okay.
Bill, in your proposal, there was a $1.9 million investment that was requested, as I understand it. Now, is that inclusive of everything for 2 years?
Yes.
Okay.
Yes, and I believe it actually goes over 4 years.
It's 4 years.
Yeah. So I guess from the standpoint of the questions from the board and kind of where we're going, how do we know that's the right number for workforce to really make a difference or to make a long-term difference in this? I guess we'd like to kind of to have a deeper dive sometime into how you came to those numbers, and I
think that's what
see
we talked about.
You've got folks behind you that have probably worked on this and are
Right.
eager to talk. So, but that's going to be really, I think that's going to be really key for us to understand those numbers and how you got there.
Thank you. Yes. Part of what Amos does is a deep dive into researching these things. So, yeah, we are very happy to share what we've learned so far and to learn more as we go through the process.
Right. Thank you. And those eager people will be able to speak here shortly.
Yeah,
Okay.
if somebody would have offered me, I think it was late 80s, early 90s, I paid about $30,000 for my master's at St. Louis University. If somebody would have offered me a deal, I would have signed it to 5 years, no problem. So,
Yeah, why wouldn't you?
yeah, so maybe, I probably wouldn't even blinked at 10. So, but, I'm from here. So, but anyway, so.
Yeah,
Are there any other
thanks.
questions, Bob? Or was that?
That was it, thanks.
Thanks.
Annie?
Right. Hello there. I'm Annie Utes with Polk County Health Services, part of the MHDS region for Polk County. I did a little bit different look when I was preparing for this meeting. I looked at what the Council of State Governments guide for ARPA money, what they're recommending that they be spent on. And when I looked at that, it really focused on some areas where you increase community integration, education, employment, and housing for people. And we know through our outcomes that we collect on the individuals that we serve at Polk County that when we increase those services for community integration, education, employment, and housing, that we see less jail days, less homeless nights, less ED visits, and less hospitalization. So when I looked at what the Council of State Government recommends, the areas that I picked out from everything that they recommended for us as our gaps is affordable housing, which we already know and you guys are addressing through the affordable housing, so I'm not gonna go into that here, but that is definitely something that I'm glad you're supporting. Addressing social determinants of health and health equity. So making sure that people have food, places to live, they have jobs. We have to make sure that we're meeting those social determinants of health. Education and employment training through re-entry services and summer education and enrichment for youth, such as camps and recreation programs. If kids and adults are involved in education, we know their mental health increases. So we need to make sure that we're getting kids and adults employed or part of recreation and enrichment programs. The mental health workforce, which has been talked about greatly already, although we've been focusing on therapists, and I want to focus on direct support professionals. These are the individuals who go into our group homes, who work with our individuals to maintain them in the community. We are seeing group homes close in Polk County because we don't have the staff for that. We have some really great programs through the e-badge system that we use in order to train our direct support professionals and frontline supervisor training. They're national programs that we use. And we would like to see an expansion of that and be able to provide incentives for staff who follow those programs. You know, these are individuals who have high school educations, who at this point in time don't plan to go to college, and we need to make sure that we have a really good base, because as we can help people live and work in the community, again, we will reduce visits to the hospital, ER, and to our jail. Also, another area is co-occurring mental health and substance abuse treatment programs. We have a few in our community, but it would be really nice to expand upon those. And once those are built, they are funded by Medicaid for those that have Medicaid. So that would be a one-time investment, although there will be some additional for those that don't have Medicaid. But for the most part, that will be covered. Also, a diversion center. Many communities are building these with their ARPA money, where it is for, some of them are for all ages, some of them are just for adults, some are just for children. But it would be really nice to have a really nice area where everyone can go for triage assessment, coordination and connection to care, behavioral health urgent care, crisis observation, sobering, for both children and adults. So a place, one building, a lot bigger than what we currently have, so that we can really provide that service and divert people from our hospitals and from our jails. And then one of the things that I know we've talked about for several years, I think now, is a welcome center for our refugees and newly immigrants to our community. But we also need to make sure that we have mental health services involved in that once that is up and built, because and they need to be culturally competent. So we need to make sure that we are providing that for our new community members. That's all that I have. I didn't go into a lot of detail because I figured that wasn't for this point in time, so.
Thank you, Annie.
Thanks, Annie. Hello, Jim Hayes from the Des Moines Pastoral Counseling Center. I'm the executive director there. Thanks for the invite to be with you today, and it's good to be with friends and colleagues who run into the same people around town all the time talking about this stuff. So I think that's a benefit to us as a community, that we kind of know who one another are, and I appreciate the support that you give to all of the people that are in this room. So thanks for doing this listening today. One of the joys of being at the end of this panel, I don't need to say anymore, really. I mean, it's been said, a lot of it. I've just been paying attention to the stuff that was on my list that hasn't been spoken to. I do want to reiterate the workforce issue, how we manage that. We've certainly explored. For us, we have about 30 clinicians. We serve about 3,500 people a year, 2/3 adults, about 1/3 of those are kids and families. So we're mostly outpatient in what we do. We do have psychiatric services and psychologists as well. So we're a small player in it, kind of between private practice and large organizations like Broadlawn's, but we do help as many people as we can, regardless of their ability to pay. And a lot of that's because of support we've received from you and from others with funding. One thing that hasn't been spoken to, that if you asked our intake coordinator, Jody, she's got the hardest job in our building because she says no all day. And the waiting list, as Terry talked about, ours is about 250 right now. So 6 to 8 weeks, and you're talking to somebody who's in a crisis, and we're not a crisis center, to get an appointment, the guts that it took to make that phone call, and then to hear no. And then what do they do next? well, do you know any place else that I can call? And Jody's got her referral list, and we work with, I know our colleague Kevin Carroll's back here, we're in their accountable care organization, we know those numbers. We said, yeah, I've called there, yeah, I've called there, yeah, I've called there, kind of a thing. So is there anything that we might be able to do just by way of data or centralization of referral lists of, is there a way that we could get some kind of a real-time system, even with private practitioners? I don't know what that would look like software-wise, but for a family that's calling, that would be a sustainable system that they could have to say, okay, here's where the waiting list is at this organization or with this person in terms of insurances that they might have. We know that a lot of places aren't going to take low-paying insurances and Medicaid and the like as we try to do as much as we can. We talked about training, but one thing I would say about training that hasn't been spoken to is when we think about diversity, equity, inclusion, and communities of color and the hurdles that are represented in taking on this profession, is the costs of supervision too. Is there something that we could do with that? So a lot of folks are going to an individual supervisor, a licensed person in the community. We usually have 3, 4, or 5 students at our place, and we just take on those costs because that's a workforce development thing for us. We're willing to pay for that training for those people, hoping that maybe they will work for us, and a good number of them do. So a way to keep people is like, how can we support them in that? That's not a sustainable number though, because we'd just be doing a Band-Aid on that for now, but what could we do to make sure that people have the capacity to pay for those hours of supervision as they're provisionally licensed or when they're doing their internship or practicum? I wonder about fundraising. There's a lot of nonprofits in the room, and we're all asking people for help with mental health, right? You get to meet all of us. We come here begging for dollars from you. Is there anything we could do to collaborate on that so that rather than having 50 nonprofits or 20 nonprofits or something like that going after the same donors or funders or something like that, is there any kind of collaboration that we could create to try and get these funds centralized? One thing that hasn't been spoken of as well, it's a little bit that came out, I think, in the Amos, I was at that listening session. When we think about post-pandemic and the trauma that we've all been through on this, people who haven't accessed mental health services before, are there low levels of preventative care or self-care that we could provide through some community relations things or messaging that we could get out on how to handle when we might be touched by this trauma 2 or 3 or 5 years from now in a way that losses that we have all suffered through this. Some of them might be minor, but some of us lost someone we love through the pandemic too. When that stuff comes up, we could do some self-care that doesn't require a therapist. So just some kind of messaging things that we might be able to do, because there's going to be folks who have never accessed mental health care before that might not be acute stuff that they need, but could help them to not have to come into a therapist by doing some of their own self-care. We haven't talked a lot about school-based things and kids and those programs. I know that we're all aware that there's need for that. Last bit for me is assessment. That hasn't come up today. So Peggy can tell us how many psychologists we have in the state of Iowa. I think we're number 48 or 49, something like that. So we're down toward the bottom of the barrel. I wonder about the modeling when people are asking about how many people do we need when we talk about workforce. Well, who's number 1 in this in terms of a state? What's their ratio for these providers compared to population? It might be good to know. That might get us to that number that you're asking about. But for psychologists in particular, we usually have around 10 of them. Doing assessment for them, they don't have the same reimbursement rates as they would for a therapy session. So our testing lists are long. This came up at Amos as well. And these are crucial services for people who are looking for disability services, who are looking for a waiver, for kids who might need some kind of an individual educational plan, an IEP for them that we could hear more about from ChildServe. That we need psychologists to do these assessments, and the reimbursement rates aren't great for that. Again, this would be a Band-Aid kind of a thing, but if there's some way that we can, even for a short amount of time with these funds, get rid of some of the backlog on these people who are utterly dependent on getting these tests done, that would be really helpful for us as a community. Those are just some thoughts for me. I'm glad to just sit in on the conversations. We're here, and I reiterate everything that came down this table are things that I was going to say too, so we're in the same place. So thank you for your time.
Thanks, Jim.
Hi, I'm Christy with Mindspring Mental Health Alliance. I don't have much to add because I think we, again, agree with a lot of people here. Mindspring is a nonprofit organization that seeks to empower individuals, families, and community by providing hope and education about mental health. One of our biggest things we've been doing is a series of webinars. We have about 47 different topics right now, all on all types of mental health topics. So as basic as stress and burnout, anxiety, into like personality disorders and understanding that. And what we've learned from these is that there's a lot of people who don't have that basic knowledge. There's a lot of people seeking that information. Our webinars are growing in popularity at an insane rate, which is awesome. But we know that people do want the information. So how do we get it to them, and how do we make it accessible and applicable to them? And I think that's been one of the biggest thing about our webinars is that people can do it privately. They don't have to show their faces. They don't have to give their names. So we're making it a safer way to do it for a lot of people. And I think that's why we're seeing the engagement we are. But specific to Polk County and not directly related to Mindspring, we would again just echo the need to focus on the direct support staff. Like we're watching that workforce fall. We need those providers, and we can't. We have all these other great ideas for other facilities and things, but that's going to take more direct care providers. So how do we build up that workforce? How do we invest in them? How do we raise wages? Because a lot of those wages they're making are not sustainable. And that's creating a workforce that's burnout and stressed, and their own mental health is suffering, and we're asking them to pour from an empty cup. So just, again, our biggest focus would how do we invest our resources is in programs to facilitate employee satisfaction and to retain employees and to increase that wage and make it a sustainable field. So we can add all these other great resources because we have a workforce that's willing to do it. But really that's all we have to say.
Thank you.
Appreciate all the comments. Just wanted to, with something Jim said, raise the note with me. I really think you've been a partner with us in developing our psychiatric urgent care. Unity Point's developed a psychiatric urgent care. I'm old, I've been in this business a long time. I really think that's the model for the future. I think calling someone, with all due, I think we get great programs around this town, okay? But calling somebody today and saying, okay, well, we'll see you in 2 months. I think that's
It's not acceptable.
No, it's not. So I think psychiatric urgent care to me is the future, and along with crisis services. So I hope if there's new people that are calling places right now, maybe we haven't got the word out well enough, but we're seeing people every day in psychiatric urgent care. I know Kevin at Union Point is as well. So I really hope we've got great staff, and I'm sure he does too. And so we've got licensed therapists, we've got nurse practitioners, got a psychiatrist, so I'm excited about the future of those programs. I'll just drive by once in a while when I retire. So, so I just think we're in the middle. I think the pandemic's pressing us to look at our models of care and how we might have to stretch. And I think to me that's the stretch point. I just don't, because we do the same thing that they're doing. We in our outpatient we schedule people 2 months, and then you end up getting like a 30% no-show rate. And it's not a good model for the future, I don't believe, for our citizens. So thank you.
Mm-hmm. Okay, did you want to say something? Yes. Okay.
I'm not used to these things. Can you hear me?
Yep.
Okay, fantastic. I'm Mathia Little-Smith, and I'm with NAMI Iowa and NAMI Polk County, Iowa. And I'm actually the designated leader for NAMI Polk County, Iowa. The reason that I've come because, firstly, I'm very committed to NAMI. I was a staff person in Minnesota, and I've been here for 11 years and training folks on everything. Right now, what's really important is to get the Polk County peer groups up and running, particularly for the people of color, which I've been here for 11 years. I have seen one person of color in our programming. I have seen none as far as when I do a lot of state training. I have not, no, that's not true. I almost lied. I've trained one. And we're partnering with Corinthian Baptist Church, And there are a couple of other churches that we are going to partner with to basically offer peer programs, which is different than the clinical. We do referral to clinical, but what we found out in research and evidence-based practices that peer support is so important to folks, particularly people of color that have a small issue dealing with the mental health field in the first place. And right now with COVID and people being, locked up, so to speak, it's been very difficult. For instance, my granddaughter called me last night. My granddaughter is 27 years old. She called me because she had anxiety. She knew what it was. She said, Grandma, I have anxiety and I'm depressed and I don't know what to do with it. She said, I tried to make an appointment with a therapist and I have to wait 2 months. She said, my mom she has a friend that has a doctor that, but this is a GP, that can get her some medications sooner than that 2 months. But like I said, I'm particularly interested in NAMI as far as our peer services go, because a lot of people that are scared to go to clinicians will go to NAMI and we'll work with them. And it's amazing how, when we have particularly the support groups, how their peers will say, well, I had depression, and one of the things that really helped me was therapy or the Step 1 program. And there's a lot of referrals and resources they can give. They will listen to their peers before they would even listen to me.
Those are those lived experiences.
Lived experiences from people that have come to participate in the support group. And all I do in those support groups is I facilitate, but they get so much information from their peers in that support group. But I also need to train folks so that they can facilitate. It doesn't make any sense that we don't have an active NAMI affiliate in Des Moines, Iowa right now. I mean, I guess we do, it's me. And we actually have 15 people that are working to reorganizing the NAMI affiliate. So I'm excited about that, but it's just so people forget about peers and lived experience, as you say. And particularly for me, people of color and LGBT folks, that LGBT folks particularly, they need a different kind of support group, because they can go to your general support group, and if you have some homophobia, they're scared to death to speak. So anyway, I could go, if you can notice that I talk a lot, so I can go on, but it's just critical to me that NAMI Polk County, Iowa expand. So
I'm glad you got here to speak.
Thank you very much.
You bet. Okay, I think with that, we're going to open it up to the anxious audience that wants to say a few words. If you'll come up to the mic at the podium.
So do you want me to move?
No, Mickey, did you want to say anything?
The only thing I'd want to say is I again agree with what's been said here. I think we really need to also look at those wait lists for children and families. I mean, we have wait lists all over the state, but one of the very beginning stages is that family and that child. If we can get them in, get them taken care of early on, then some of the other things we're dealing with on the adult side or as they move through the system and getting those supports. So as we look at that whole continuum is where do we start and how can we help those families at the very beginning so that as they grow older and stuff, they have the supports that they need within our system.
Good point. Thank you. Okay. step up to the podium, state your name and address, please.
Hi, good morning all. My name is Lalmoni and I am originally from Burma and I am working at Embark as a family-focused advocate. And I am a mother of 4 kids as well, and almost every day I'm working with 70 plus moms. I'm supporting them as needed. And I'm here, I wanted to talk about the mental health is really important in our community. And more importantly, we really need to get a mental health therapist in our own language, who can speak our own language. Because when people notice in our community, when people notice that like they need help, but they don't know where to go and they don't know who to talk to. Because in our community, there is a lot of gossip going on around. So let's say somebody's open up to another one, and that person will be, telling their story to another person. So like the next day, everyone in our entire community will know about them. So that's the thing they worry. And even the child get bullied in school and they don't think their parents can help them. So, at the end of the day, they try to commit suicide. And last year, we lost a lot of people because of their mental health situations. And also, since I am advocate at Embark, I also interpret for a lot of our community members. And one of the family that I work with is, he has 3 daughters, and he has been going through with separation with his wife, and that really infecting to his and his kid mental health really badly. And when every time I go to family therapy session to interpret, I feel that I find it really difficult for me as well because I am not specifically trained to interpret for mental health situations. And those kind of words is really difficult for me to find in our own language as well. And so that's the reason we really need someone that can speak in our community, especially like immigrant and refugee background, so that we can talk, our community people can talk to them with their own language and with, like truthfully and really trustfully, So yeah, I just wanted to share with you all. Thank you so much for your time.
Thank you.
Thanks.
Good morning, and thank you for the opportunity to just come and talk about system gaps. My name's Allison Simmons. I'm the founder and executive director for the Central Iowa Trauma Recovery Center. We are located on the south side of Des Moines, just south of Waterworks Park. We are a multidisciplinary team of professionals, mental health, victim serving, healthcare, working to provide services and support for survivors of trauma and loss. We have a relationship with the Iowa Attorney General's office, and I want to talk about mental health because I think the population that we see is a conversation that has not been shared today, and that is victims of crime. We work in partnership with law enforcement, with community members. Many individuals find us after they've been victimized, they were just out in the system and needing support. We have approximately 25% of our clients come from other victim-serving agencies. We provide on-site mental health treatment. We have an innovative therapeutic, it's really holistic environment, so we have wellness space for clients who've experienced trauma. We're able to do bedside evaluations, home visits. We are designed to be mobile, but I would say that there exist robust systems for domestic violence and sexual assault, but those other violent crimes are just lost in the mix. And that's who we serve. Those assault victims, those homicide survivors. About 25% of our clients are homicide families, surviving family members of a homicide. And we also, although we're not funded to do this, but we volunteer for crisis response for law enforcement for suicide, which has been an increasing issue with children here of late, just an increase and a surge in that. It's important that these services are available to survivors. We utilize an evidence-based model. I actually serve on the National Alliance of Trauma Recovery Centers. We're a network of 39 trauma recovery centers across the country. that are implementing this holistic model of care that's cost-effective and clinically effective. It's 34% less expensive than traditional fee-for-service care for mental health. What we find is that when you provide intensive support services for people who've been victimized, they get better, faster. That's what we're hearing from law enforcement. It's a call. They know that these folks are going to get immediate mental health treatment. Within 24 hours, we're able to do a clinical evaluation, get those folks into care. We also have the opportunity to measure their progress over the course of their stay with us. We employ interventions that have been tried and true. We've been able to determine that this works in urban centers, in rural areas, where folks have been disproportionately impacted by crime. Our staff is multilingual. We have a diverse population of clients that we currently see. It's comprehensive care. It's not designed to be a mass number of folks, but what we do is we're changing neighborhoods one family at a time. We're able to see that people get better, faster, and they're less reliant on other state-supported systems of care because they're able to return to work. We provide, it's that integration of mental health and victim services, but it's a higher level of care because people are able to get that access immediately. Some of our clients, we know that in terms of determining eligibility for crime victim compensation, it takes 2 months. So you have this individual whose life has just been turned upside down, and they're just out here suffering needlessly. And so we're saying that when you're talking about mental health, please allow us to introduce the need and support for survivors of crime. I thank you so much for your time today.
Thank you.
Good morning. My name is Mupon, and I was born in Burma. Because of civil war, my family flipped to Thailand refugee camp, and I was growing up in Thailand refugee camp. So I came to the United States in 2010 and moved to Des Moines in 2013. I graduated from Grandview University with a Bachelor of Social Work in 2021 April. I am a community member of current community member, and I am a navigator at Embark. So as a navigator, I work a lot with their family with the direct support, so like directly with the client, to support them with the knowledge and skill that they need to support their family. Personally, I think mental health is very important. We should have like professionals who are in bilingual, because like refugee community, there are many mental health issues that they are experiencing, but like they don't know what it is, where to talk to, like who to talk to, where to go. And there's a lot of time that they are very isolated. There are many issues and many stories, but today I will only share one story with you all. There is a correct community for Burma, live in Des Moines, a father who spanking his son with the hanger, and their son told their teacher, and then the DHS got involved, and both parents don't know what to do, like where to talk to. But they are very depressed, so like they don't know. So to the point that the father is committed suicide. So if we have a person who helped the father through with this situation, the situation might turn a different way. That's why I chose social work field, because I want to fill the gap. Thank you.
Thank you.
Good morning. Can you guys hear me?
Mm-hmm.
Well, I wanted to say thank you for giving us the chance to be here. I'm Derly. I'm from Colombia. I came here at the age of 15 because I was adopted by my family. I grew up in an orphanage, and then honestly, I struggled a lot when I came here as a teenager. I couldn't adapt or connect with my family because I had a lot of attachment, and it was hard for me to receive therapy because in our community, it's kind of a taboo. what happens at home stays at home. So I wasn't ready to receive the help. But now that I have a therapist that is from Colombia, I can see what is the importance of having somebody that looks like you and speaks your language. My own life experiences have cultivated a strong desire to also become a therapist and help other people in my community. I also graduated from Grandview in 2020, and currently I work at Orchard Place as their biggest worker. I see a high need in therapy for parents. All of our kids are required to have a therapist, but many times I see that their parents need to address their own trauma to better support our kiddos. Many times I can see in our sessions when moms talk about their pain, and it's hard because I'm not a therapist and that's not the right space for them to talk about. We try to find resources for them, and it's been really hard because first of all, there is not insurance. Oh, I'm sorry, am I speaking back and forth? There is not insurance, and then a lot of services are not for undocumented individuals. So it's really hard to kind of feel hopeless to find them resources. I can think of a mom that, because of her own trauma, their kid couldn't make any progress in BS. So I had to discharge them. But I truly believe if she can address her emotional needs, she can better support the kids. Because of moms like her, I want to become a therapist. I want to support her, and I want to provide that space where she can talk and address her mental health. Thank you for the support that you're giving us, and it's great work, and I hope that you guys see the need in bilingual and color therapists in our community.
Thank you.
Thank you.
I want to thank you for allowing all of us to come up and speak to you about the need that we have within the community. My name is Joyce Bruce, and I was employed with the Des Moines school system for over 20 years. I am now a very happily retired person, and I volunteer at various schools, and I have had the pleasure of mentoring students for over the last 6 years. And it is really and truly an opportunity that I have enjoyed. However, this year, I have come in contact with students who have suffered through the pandemic and is now attending school, and it has been a real trial for them. To be home, away from their friends and their daily routines, that has caused children's behavior to change. According to a model court presentation that I viewed, 25% of today's youth is experiencing depression, 20% suffers with anxiety, and therapy or medications are needed and not available. Compulsive behaviors have increased, with children acting out repeatedly in the school's hallways and classrooms and just absolutely refusing to complete any assigned classroom work. And this is the reason why homework is no longer assigned. Youth suicidal rate has increased since 2019. Females committing suicide, their suicide rate has risen since 2019 to 51%. And males are up 4%. And this is really the reason why I am here with you today, as I have noticed more children, especially girls, crying continuously in school. And it is very challenging to locate services for them. Des Moines Public Schools has an extreme shortage of social workers, therapists, and counselors, especially those that speak more than one language. Des Moines Public Schools, which you may be very aware of, has over 100 different languages spoken in their schools. I had the good fortune to mentor a student whose friend committed suicide, and the family only speaks Burmese. And when I reached out to the student and learned about their needs and the fact that we had to find an interpreter to go in to visit with the family that spoke Burmese, I reached out to Embark for services for this young lady. And the reason for that is because of the girl who committed suicide. Her brother attends the school where I am at, and he needs services. And I am another student that I am very concerned about. His father just died from COVID, and that family speaks Arabic. That's the need for another interpreter. Unfortunately, I am asking you to please consider Amos' proposal for ARPA funds to support social workers and therapists working to obtain their certification, and especially those from the various cultures. As you know, Des Moines population is very diverse, and the school where I'm at, they only have a therapist that comes one day out of the week to service children. And the school presently has a waiting list of over 30 students needing services. I want to thank you for listening to me. Thank you.
Okay, is there anybody else that wants to speak? As you can see, we got a lot on our plate with mental health. There's only so much money that'll go around, so we're gonna have to be very strategic and prioritize some long-term strategies, but I think we can do it. There's great programs out there. I think workforce is definitely a #1 issue for us. We've got to get therapists and counselors and social workers back in the workforce. We've got to figure this out, and how can we make a significant impact on that? We need children's services. We need to have them get access. There's just a lot of us to think about what we can and cannot do. So I really thank you for you all being here and really taking the time. I know, appreciate Amos and their work in December, doing that work. I think you laid the groundwork on some of our workforce issues, and I really appreciate that. And I'll look at your 8-point proposal, Steve. Who comes up with 8 proposals?
And I knocked a couple off.
Okay, great, thanks. As I can say, we can't do everything, but there's a lot of needs out there for sure. If I could put everything in one building, that's what I'd really love to do, but I am not queen for the day, so I can't really build a building and say we want to put everything in one building, but that's ultimately what I'd love to do, is have one big, I don't know, what'd you call this, a what? Yeah, that's what I want, but we'll see. Anyway, thank you all for coming, and stay tuned. We'll set up another meeting, and staff will get back to you on that. So thanks, Sarah, for getting this set up. Appreciate it.
Thanks, sir.